Yeah, but I just figured you're going to give the public a false sense of security because it's not really a full, I mean, it is emergency room with the personnel and everything you have there, but as far as for additional service, I know you talk about that, I guess it'd probably be a critical care transport, which I'm very familiar with that. I've done that before because there are some facilities that use it, may not. But just the fact that it's just a freestanding alone ER is not something I'm comfortable with, and I don't think the public would be either.
Thank you, Assemblymember Burke.
Can you just address for me the fact that they would be receiving, because here's the thing, I just had a district that went through a hospital desert. I understand the issue you're trying to solve here, but my question would be, why would they still receive ED prices if they're not going to have the same ED requirements?
But that's just the issue. They will have the same ED that they have today from the standpoint of, because when you receive surgery or you get admitted, it's a separate bill. The ER bill has always been and always will be a separate bill, and it's billed separately from the inpatient services. So if you're talking about the billing standpoint, they're still going to be seen by the same type of physician with the same type of services and the same type of equipment. So therefore, they're getting the same care they get today. But if they go forward and have to have surgery, that's always been a separate bill if they have to be admitted into an acute care facility. It's always been a separate bill.
Is that the way you...
However, from the standpoint of, if an ER needs to bring a specialist in, if they need to, access, other sorts of services, that is built in. And Medicare just does not, they're not going to allow, if it is an urgent care center, for that center to bill them. This looks just like an urgent care center, but if the state designates it otherwise, then they are allowed to bill to Medicare, for example. And so from that billing distinction is really up to the state. And there are fewer, a handful of states that allow this, but from a patient care standpoint, and in terms of what we're trying to achieve in healthcare, driving care to the lowest cost setting, getting the highest quality, this is the inverse of that. It's driving people to the highest cost setting without justification on the quality of care side.
Assemblymember Ridley Thomas.
Mr. Bro, new to this topic with respect to your specific area, very concerned about it. You may have read the LA Times this past week. Los Angeles County is having a conversation about emergency departments and services in Pomona, the Pomona Valley area, and in southeast Los Angeles. I'm not yet comfortable with this proposal, but I would like to suggest an idea, if it makes sense to you, that we make this an interim subject matter where we have an interim hearing to discuss your bill and emergency services in the Southern California area, because I think you're barking up the right tree and you're moving in the right direction. I don't know that this is necessarily the proposal that I can personally support. I don't know what your opinion of that would be, or other members of the committee, but with the chair's indulgence, I'd like to see it go to an interim study committee setting where we can really tease these issues out, produce another analysis, analyze where we are in the late fall, early winter, and see if we can actually get a solution on this, because this is a critical challenge. And if I'm in Orange County and have an emergency event, I want to make sure that we have of course, a robust safety net, and I don't think there's any reason in any other California shouldn't have that protection. So I don't know if you have a response to that.
I'll absolutely take you up on that offer.
All righty. With that, Mr. Chair, I make the motion to move this to an interim hearing.
Okay, let me just try to clarify what's happening here. So, according to Assembly Rule 59, the subject matter of a bill can be referred by a standing committee, that's us, the Health Committee, to the Rules Committee for assignment to interim study. It would probably get referred back to the Health Committee. And then we would spend some time studying it. Essentially, this becomes a 2-year bill at best. No bill will get passed and signed this year, to be perfectly clear, Assemblymember Bro. That means the soonest a bill could possibly get passed and into law without an urgency would be January 1st, 2017. So I just want to make sure you understand what you're agreeing to.
Thank you, Mr. Chairman. Yes.
Okay, so you continue to agree to that?
I agree, yes, sir.
Okay, we have a motion, we have a second.
We don't have to vote on it.
Okay, a vote would be required if there were an objection. I haven't heard an objection from any committee members, so that being the case, it is assigned for interim study.
Thank you, Mr. Chairman and members.
Thank you, Assemblymember Bro. Thank you. Next, we have item number 31, AB 1526, Aging and Long-Term Care. Assemblymember Brown, as the chair of Aging and Long-Term Care. Whenever you're ready, Assemblymember.
Thank you. Mr. Chairman and fellow members, AB 1526 is a simple bill. It asks the Department of Public Health to expand an existing telephone survey conducted throughout the year about behaviors that impact public health. That survey is known as the Behavioral Risk Factor Surveillance System, and it collects data that informs our health provider partners. That survey is sponsored and overseen by the Centers for Disease Control in Atlanta, Georgia, and every state in the nation participates, creating a nationwide assessment of risks that impact public health. CDC also offers an optional question that states a different module. Do you have those? Oh, you're passing them out. Okay. Additional questions. These are the additional questions I'm asking the DPH to use relative to caregivers. You're getting those copies right now. And what they would do is this module will help California establish a baseline data on issues that caregivers confront most. This data is critical if we are to support the number of caregivers providing support to our aging and disabled residents. As you know, informal caregivers provide $48 billion of care, free care, every year. And there's no program. I would like to introduce Susan DeMorris from the Alzheimer's Association and sponsor of the measure.
Good afternoon. I'm Susan DeMorris here on behalf of the not-for-profit Alzheimer's Association. We have 21 offices throughout California serving your constituents with Alzheimer's and related dementias. I would urge your support of this bill. It is comprehensive. It's much broader than Alzheimer's. It includes autism, cancer, diabetes, heart disease, mental health issues, substance abuse, and a variety of disabling and chronic conditions that affect your districts. This survey is administered annually by the Department of Public Health. We have the infrastructure in place to begin work on this immediately. And though this isn't the Appropriations Committee, the cost of adding this one question to California's existing survey using existing resources would be less than 2 cents per every caregiver, the 4.4 million caregivers in California who provide unpaid care to loved ones in their home. Thank you for your consideration.
Thank you. Additional witnesses in support? Seeing none. Any witnesses in opposition? Seeing none. Any questions from committee members? Seeing none. The committee can entertain a motion. Sorry, we have a motion in a second. The motion is due pass to appropriations. Assemblymember Brown, would you like to close?
I sincerely ask for your aye vote.
Thank you, Assemblymember. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Bonilla? Burke? Burke, aye. Chavez? Chu? Gomez? Gonzalez? Hernandez? Lackey? Aye. Lackey, aye. Nazarian? Aye. Nazarian, aye. Patterson? Patterson, aye. Ridley Thomas? Aye. Ridley Thomas, aye. Rodriguez? Rodriguez, aye. Santiago? Steinnorth? Steinnorth, aye. Thurmond? Waldron? Waldron, aye. Wood?
Okay, we're going to go to Waldron first if he doesn't get here before then. Okay, thank you.
Wood? Wood, aye.
10-0, you are out. Congratulations to Assemblymember Brown. Thank you. Next, we're going to go to Assemblymember Waldron. See no other non-committee member authors present at this time. I understand one is on his way, but we'll go with Assemblymember Waldron. You have item number 2, AB 73. Please proceed at your pleasure.
Thank you, Mr. Chair and committee members. I will be taking the suggested committee amendments to expedite the appeal process of 48 hours for these protected classes. AB 73 addresses a nonpartisan issue that strengthens the doctor-patient relationship by legislating an expedited process within the prior authorization utilization controls, very specific and protected therapeutic drug classes within Medi-Cal program, and currently formularies and step therapy programs are not always sufficient to treat certain vulnerable populations. And that is why the federal government enacted Medicare Part D, and AB 73 creates a similar protected class structure for drugs prescribed by the Medi-Cal beneficiary treating physician that would be covered under the Medi-Cal program. And I will make my comments brief. I do have with me Jerry Jaffe with the California Chronic Care Coalition in support.
Jerry Jaffe, California Chronic Care Coalition. I don't have anything else to add to her remarks other than just to mention that the amendments that have been drafted based on the committee analysis are very good, and they still stay within the spirit of the Provider Act and would still stay in, within that area. So would urge your support for the bill.
Additional witnesses in support.
Jimmy Jackson, Biocom, in support.
Eve Bukowski, the California Healthcare Institute, in support.
Erin Norwood on behalf of Beringer Ingelheim, also in support.
Greg Herner on behalf of the Leukemia and Lymphoma Society, in support.
Thank you. Witnesses in opposition.
Beth Capel on behalf of Health Access California would like to thank the author for her efforts and the committee for its work, and with these amendments we do remove our opposition. Thank you.
Mr. Chair and members, we got the amendments during the hearing, so we haven't analyzed them fully, so we maintain our opposed position. Thank you.
Thank you. Additional witnesses in support. Seeing none. Questions from committee members? Seeing none. We have a motion. We have a second. The motion is due pass as amended to appropriations. Assemblymember Waldron, would you like to close?
Thank you, Mr. Chair and committee. I urge your support for this bill. It really protects vulnerable, low-income individuals and allows them to have access to needed medications. So it's really an access bill, and it helps those who may otherwise not be able to get the drugs in a timely manner. I urge your support.
Thank you. Due pass as amended to appropriations is the motion. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Bonilla? Burke? Aye. Burke, aye. Chavez? Chu? Gomez? Gonzalez? Hernandez? Lackey? Aye. Lackey, aye. Nazarian? Aye. Nazarian, aye. Patterson? Patterson, aye. Ridley Thomas? Aye. Ridley Thomas, aye. Rodriguez? Aye. Rodriguez, aye. Santiago? Steinnorth? Aye. Steinnorth, aye. Thurman? Waldron? Aye. Waldron, aye. Wood? Wood, aye.
10-0, you are out. Congratulations, Assemblymember Waldron. We're next going to call item number 6, AB 374, Assemblymember Nazarian.
Thank you, Mr. Chair and fellow members. I believe I have two witnesses that are going to be joining me shortly. they're already here. More than 16 million Californians have a chronic condition. Individuals with chronic conditions are greatly impacted by health plans and insurers' reliance on step therapy. Under step therapy, patients are forced to fail first on several alternative medications before they are permitted to obtain the medication deemed appropriate by the provider. Anecdotal data shows that plans may require a patient to try up to 5 different medications before receiving access to the medication prescribed. Also, the duration of each step is up to the health plan and has been known to last at least up to 90 days. AB 374 allows a prescribing physician, based on his/her professional judgment, to request a step therapy override determination from a health plan or insurer on behalf of a patient. The bill sets forth 5 criteria at the basis for the request and requires adequate supporting rationale and documentation from the physician. This bill does not prohibit step therapy protocols. Rather, the bill establishes an override determination request to ensure patients' unique needs are considered. The existing process is not balanced. The plan or insurer controls the medications a patient is allowed to try. The insurer is not the treating provider and is unaware of the individual circumstances or pain a particular patient may be enduring. Use of step therapy leads to an exacerbation of a patient's condition, causing irreversible deterioration or damage to the patient, such as limiting their daily functions and ability to remain a productive member of the workforce and society. With me are 2 witnesses, Dr. Wesley Mizutani and Doug Chiappetta, who I believe is not here.
Thank you, Mr. Chair. First and foremost, I'd like to thank the Assembly member for his leadership on this issue. Kristen Hare with the Arthritis Foundation, one of the proud sponsors of the bill. With me today, I have Dr. Wesley Mizutani. He is the chair of our California Advocacy Council, a board member. He is also the Director of Clinical Research, as well as the Department Chair of Rheumatology with Healthcare Partners. I'll be available for questions, but I'm going to go ahead and give the rest of my time to Dr. Mizutani.
Thank you, Kristen. Thank you, committee, for having me the opportunity to speak to you this afternoon. As a practicing rheumatologist, I treat hundreds of patients with a spectrum of different arthritic conditions, from rheumatoid arthritis to lupus to fibromyalgia. Arthritis is the leading cause of disability in the United States. It affects over 5 million adults in California, as well as 38,000 children. Among the arthritic conditions, probably the most serious in terms of debilitating is rheumatoid arthritis. Recently, several studies have shown that early aggressive treatment, including biologic therapy, results in better outcomes in rheumatoid arthritis patients. What does this mean? It means prevention of joint destruction and disability. One obstacle we as clinicians encounter in attempts to achieve better outcomes is acquiring approval from health plans for optimum treatment regimens for our patients. For example, I recently saw a 30-year-old female patient with rheumatoid arthritis for 6 months. 6 months is a brief time for most patients with rheumatoid arthritis. However, when I saw her in my office, she already had evidence of joint destruction both on x-rays, and she already had deformities in both the fingers of second and third finger of both hands, and was unable to extend or flex her right wrist. So that even though she had it for a short time, she had already destruction and made it difficult for her to work where she was a cashier at a retail clothing store. Clearly, she fit into the early aggressive disease with a poor prognosis as defined by the American College of Rheumatology. In most practices, this makes up less than 5% of the entire rheumatoid arthritis population. In order to comply, though, with step therapy policies, she was required to take either methotrexate or Areva for at least 3 months before she could qualify to receive biologic treatment. It was my belief that aggressiveness of her disease warranted biologic therapy now and not 3 to 4 months from now. We complied, however, with the step therapy mandates and began on methotrexate. She encountered some nausea initially and then made it slower to escalate the dose. However, after 6 months, she attained the required level for methotrexate. However, her deformities got worse. She had to quit her job because of disability from unable to function being a cashier. and so that we then submitted a request for her to receive the biologic treatment. And although it was approved, it took a month for her to actually receive the medication. With AB 374, in cases such as these, we will be able to request a step therapy override from a plan based on medical necessity of a particular patient, and hopefully will prevent irreversible joint destruction and permanent disability in patients like this unfortunate young patient of mine. Thank you.
Thank you. Additional witnesses in support?
Jimmy Jackson, Biocom, in support.
Eve Bukowski, California Healthcare Institute, in support.
Greg Herner on behalf of the Leukemia and Lymphoma Society, in support.
Patrick Stone, National Psoriasis Foundation, in support.
David Ford, Association of Northern California Oncologists, Medical Oncology Association of Southern California, and the Pharmaceutical Research and Manufacturers of America, all in support.
Linda Way with Western Center on Law and Poverty, in support.
Nancy Murish with the Congress of California Seniors, in support.
Alex Hawthorne on behalf of the 7 California affiliates of Susan G. Komen for the Cure, in support.
Rebecca Gonzalez, National Association of Social Workers, California Chapter, in support.
Autumn Ogden with American Cancer Society Cancer Action Network, also in support.
Teresa Anderson with California Academy of Physician Assistants, in support of amended position, and we want to thank the author and sponsor for working with us on that, on those amendments for provider neutral language.
Khalif Osagai on behalf of NAMI California, in strong support.
Jerry Jeffrey, representing California Chronic Care Coalition, in support.
Bill Remack, California Hepatitis C Task Force, in strong support.
Thank you. Witnesses in opposition?
Michael Hawkins, representing Celgene, in support. Thank you.
Now witnesses in opposition.
Hi, Mira Morton here today on behalf of the California Chamber of Commerce, respectfully opposed to AB 379. In 2012, the governor vetoed AB 369, which prohibited plans from requiring more than 2 steps before providing prescribed pain medications. And in that message, importantly, he expressed skepticism that the current law does not suffice to protect patients and ensure rapid access to care, and also required that any solution would need to strike a balance between the role that physicians play in their discretion for prescribing medications to their patients and also plan oversight of that discretion. And we believe that this bill does not address either of those concerns. This bill also deals with all medications, not just painkillers, so it's much broader than that former measure. It gives plans a smaller role, and actually we would argue that one of the exceptions provided in the rule would actually basically prohibit step therapy outright, depending on how it's interpreted. We believe it's important to allow an enrollee to make an argument, that they have a medical necessity for this and that the current exceptions already honor those exceptions, honor the doctor's role in understanding the uniqueness of a patient, and therefore these other exceptions are unnecessary. Number 3, in particular, that I'm referring to, talks about the prescription drug required by the plan is not in the best interest of the patient based on medical appropriateness as determined by the doctor. So that's basically because your doctor says so. That would create an exception for step therapy. So for us, that's incredibly broad and basically makes this a ban on step therapy protocol. This is important to our members because increasingly our members, our employers are under pressure to provide health care to their employees to make sure that that health coverage is high quality and to make sure that they don't have to pass on additional costs to their employees in the form of larger shares of their premiums to create larger deductibles. And as we've heard today and will continue to hear, drug prices are part of that. Also, step therapy is not just about cost. It's also about making sure that you give patients the most efficient, most effective form of the drug that is the least expensive. So, again, it's not just about the cost. It's making sure that we're keeping them safe and getting them the right treatment, not just the one that they asked for because they saw a commercial for it. So we believe, despite assertions that we've heard, that this actually will decrease outcomes by having individuals go through step therapy. If you look at the CHBRP analysis, they have found insufficient evidence that step therapy creates negative health impacts. And as a result, we believe they're a proven, efficient way to ensure that patients get the most affordable, least dangerous medication that addresses their medical needs, and we urge your no vote.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. While we appreciate the author and the sponsor's commitment to this issue, unfortunately we do have serious concerns about the current bill in print. Prescription drug coverage is a key component of quality health care, and it's imperative to ensure that patients have access to the medically necessary care they need. However, the continuing escalation in price for these drugs requires innovative pharmacy programs designed to ensure that the care is received at an affordable cost. The evidence-based measures approach involved with step therapy is tailored to individuals and carefully gauges a patient's response to less harmful medications before graduating to more high-risk drugs. In the case of abused or potentially addictive drugs, step therapy protocols are a powerful tool to reduce the risk of overmedication, abuse, or addiction while maximizing the disease management and treatment. The decision to ask and ensure to use a more safe and established drug regimen at the beginning of treatment is based on our member companies conducting evidence-based reviews and reviewing the appropriate federal drug and Food and Drug Administration guidelines. Requiring health insurers to provide an override without any regard to carefully developed guidelines will not help control costs and could result in harmful side effects to the patient. At a time when prescription drug abuse has become one of the nation's fastest growing epidemics, it's critical that insurers continue to be diligent in their efforts to ensure that providers are delivering quality health care to their members and that they are adhering to evidence-based practices. The bill is counter to that goal and severely diminishes an insurer's ability to provide the necessary oversight this class of drugs warrants. For those reasons, we remain opposed. We appreciate the author and sponsor did meet with us, and we did air out some of our concerns. But at this time, the bill in print, we're not able to support it.
Thank you. Additional witnesses in opposition.
John Caldwell on behalf of the Pharmaceutical Care Management Association in opposition.
Allison Ramey with Blue Shield of California in opposition.
Jennifer Gabals with the California Association of Health Plans in opposition.
Julianne Broyles here on behalf of the California Association of Joint Powers Authorities and the California Association of Health Underwriters in opposition.
Maureen Higgins on behalf of Express Scripts and America's Health Insurance Plans in opposition.
Thank you. Seeing no additional witnesses in opposition, questions from committee members? Dr. Wood.
Yeah, I just have a question, and I'm not sure if anybody out there can answer it at the table, but I'm hoping somebody could. So what happens if a patient goes through step therapy and then changes insurance? Do they get to go through step therapy again?
My experience is that's correct. When we have patients who are on higher level tiered drugs, mostly brand name drugs, and they switch insurance plans, then my experience is that we get a 30-day notice from the new health plan that says that drug is no longer covered under the new plan, and that we would have to fill out a prior auth.
I guess I just fundamentally think that would be unfair. If you've been through this once, and yet changed plans, you'd have to go through it again, and I have a hard time believing that is in the best interest of patients in the long run. So,
I would agree 100%.
If somebody else has further information, I'd love to hear it. So, okay, thank you.
I'm happy to get back to you on that. I don't want to give a wrong information now. So I'll just get back to you rather than saying anything right now.
On that point, Dr. Wood, I just want to point out to a portion of our analysis, of the staff analysis, existing law, which starts on the first page. It's actually paragraph 3 that goes to the second page, and it says existing law prohibits in situations where an enrollee prohibits in situations where an enrollee changes plans, the new plan, from requiring the enrollee to repeat step therapy when that enrollee is already being treated for a medical condition by a prescription drug, provided that the drug is appropriately prescribed and is considered safe and effective for the enrollee's condition. So that may be, at least in part, responsive to your concern.
That's the answer. I'm sorry, I didn't catch that part.
No problem. Additional questions, Dr. Wood?
Well, I heard reference to high-tier medications, but step therapy applies to lots of lower-priced medications as well. I will tell you, for example, I was recently prescribed something, but was, quite frankly, told that I needed to use ibuprofen for 4 weeks before I could get to the next medication. I'm not kidding you. This is absolutely true. So that it isn't just the high tier medications that are affected. So,
Assemblymember Chu.
Thank you, Mr. Chair. To the author, I was wondering if you could respond to the sorry about that. If you could respond to the questions raised by the opposition that your bill would contribute to the rising cost of health care by making it more difficult to cap expensive prescription medications.
Thank you. I'll actually ask Kristen to follow up on it, but I'll just briefly, first of all, take the opportunity also to respond to some of their concerns. First of all, the bill that was vetoed previously was much more prescriptive, and it only allowed for 2 failed attempts. This is much more permissive. This allows for the doctor to figure out, or the prescribing physician to figure out where to draw the line. And quite candidly, it's an issue of control that I think rightfully plans would not want to let go of, because it gives broader opportunity for the doctor to decide, the physician to decide. As for the CHBRP analysis, from my understanding of it, it did not necessarily suggest that it's going to be increasing cost. In fact, over the long term, it has the potential of reducing costs. And at this point, I'll ask Kristen to chime in and follow up on that.
Yeah, and to add upon that, one of the things that we've, Assemblymember Nazarian pointed out, is that in past the bills have been much more prescriptive. They were across the board. This bill is really targeting a very small subset of the population that would meet one of the 5 criteria laid out in the bill, and that would then allow for the request to be made of the plan. There would still be the option to review it, and that's one of the amendments you'll see in the analysis is changing a word from granted to reviewed, and so there would still be some oversight and discretion on the part of the plans. So it wouldn't be like in previous versions of outright, changes to all step therapy protocols. It's in these very specific cases where, for example, in our case, the rheumatologist looks at the patient, looks at the step therapy protocol, and takes it into their clinical judgment to say that in this particular case, we should request an override.
And I think I would just say I'm open to supporting this approach, but as you and I have discussed, that is really my top concern as we're trying to figure this out. And I think there really is an open question on this, but appreciate your answer on that.
Additional questions from members? The committee can entertain a motion. Committee can entertain a motion. Dr. Wood seconds. We have a motion. We have a second. And a clarification. Assemblymember Nazarian, are you accepting the technical amendments proposed by the committee? Yes. Thank you for the confirmation. We have a motion. We have a second. The motion is do pass as amended to appropriations. Madam Secretary, Assemblymember Nazarian, would you like to close?
I respectfully ask for aye vote.
Thank you. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Bonilla? Burke? Chavez? Chu? Aye. Chu, aye. Gomez? Aye. Gomez, aye. Gonzalez? Gonzalez, aye. Hernandez? Lackey? No. Lackey, no. Nazarian? Aye. Nazarian, aye. Patterson? Patterson, no. Ridley Thomas. Rodriguez. Rodriguez, I. Santiago. Steinnorth. Thurmond. Waldron. Wood. Wood, I.
Current count is 7-2. The bill will be on call.